folks, this is Arun for CPNR. Today we are going to look into one of the commonly done techniques in physiotherapy, that is preparing the patient for treatment. Right? You may be confused with the terminology if you have not studied in that particular manner. Now, before starting any exercise, which is functional exercise, right? A lot of people tend to do preparatory techniques to reduce a lot of things or improve a lot of things. Those things are called as preparation of the patient, right? You might have not heard of the name as such, but it's common to all of us to do, say for example, passive movements, passive stretching, individual activity like bridging or doing wrist extension if it is possible, that kind of things, right? So that's what they call it as preparation of patients. Why do they do that? They traditionally it's been done to breaking this energy. If you have flexor energy, you tend to do breaking the flexor energy before starting your extension. You tend to do it to reduce contractures, prevent contractures from developing, that kind of thing. And also you want to do part movements before doing the whole movements. What I mean by that is before starting to walk, right? You can see that in your cash textbook also. You will first start with activation of your hip extensors. So you tend to do bridging. Then you make them sit in the couch and make them do knee extension flexion to elicit knee flexion and extension, and then make them walk. That kind of thing is what I mean by doing parts before doing the walk. The exercises which we give for doing these things, or how do we achieve these things, is commonly we do a weight bearing exercise, right? That is basically to break the synergy. We think that if a patient comes like this, right, we have to first keep it in an extension there. Then you have to go into that kind of ideas. You tend to do passive movements and passive stretching to prevent contractures and reduce spasticity, if you will. You can also do holding of the limbs in different postures, right, like this. You keep your hand in one particular posture, that is the shoulder like this, like this, like this. That kind of thing is slightly uncommon, but that's also part and parcel of what we call as preparation of the patient. I suppose the two common things which we do is, or three common things is weight bearing, passive movements, isolated exercise like bridging. Now, the assumption we make is, as I told you, the parts, if you do the small parts, the whole will get corrected. Of course, that is not possible, which is what the evidence is also telling, but just to give you a simple explanation of why this is not helping us. Now, the first thing you want to remember, you cannot change the muscle length, whether you are doing it for sports people or people with UML lesions. The length of the muscle does not change. When the muscle starts activating, actually changes. That is a function of the brain and it cannot be changed. That is especially by doing any passive techniques. You can also not prevent contractures and tightness developing by giving passive movement or passive stretching. That again is not happening because again it's a function of the brain and you need the brain to change. If you want to change your brain, we all know that has to be happening actively. That is, there should be an active participation from your patient, whether it is spasticity reduction or changing the length of the muscle, that kind of things. So just stop. This is of no value to anybody. I get a lot of people say that no, patients are asking me to do because this and that. That is not how medicine works. You are not a drug peddler for giving what your consumer wants. You are a therapist and you need to give the patient the best care possible. And also remember, the patients don't know any of these things. We only teach them. So we have to stop that. The next thing is the individual movements or breaking the synergy. Remember, any organisms, interacts with an environment to produce a functional task, that's when you get a movement. So if you correct the organism or if you correct the environment, that is not enough, right? So you need to change the whole thing. So if you activate your hip, the gluteus or the hip extensors, that doesn't mean you will walk with an extension. That is not how it works. Hip extension happens by a complex symphony of your movements of the body, which is controlled by your brain in accordance with an environment. You can't separate the environment and the body, as well as you can't separate the task needed, that is the function to be completed, that is the gait and the extension which it requires. So doing individual movements, putting them on a ball and making them bounce like as though they are in a circus, or rolling them on this and that, all sorts of things should be stopped. They are not physiologically justifiable, or they are not backed by evidence, right? So stop all these things and start making your patient do active movements, especially functional active movements. If they can't do it, that means probably your rehabilitation has to be in a different manner rather than making them do that activity. That we will see in another video. Thank you so much for watching. If you are happy with this, like and subscribe. Bye bye.